Yes, sir.
Yeah, sure.
Yes.
Again, from our own block. So we have finished on acetabular side, couple of osteotomies. Today we will try and complete the osteotomies on the femoral side. So this is the first osteotomy which describe, I told you, McMurray osteotomy. And my boss had a opportunity to work with him. So he did a couple of McMurray osteotomies at Bombay Hospital, which I'll show you our experience. It was mainly at that time, we did it only for a non-Indian fracture neck femur in India. So everybody did a right and left with all modifications, but they were not good, not good. So it was a clearly different described. Actually, he described later also for osteoarthritic knee, osteoarthritic hip, but unfortunately we didn't had a much OA hip in our country. Today we do see OA hip in our country, which is followed by due to the femoral acetabular impingement, secondary arthritis. But initially we did not see, so we didn't do much osteotomies for the osteoarthritis. So we did a lot of number of cases for a fracture neck femur because we didn't had a choice at that time. And in osteoarthritic, you should not displace too much, more than 20. You should do a small displacement. Reason is, if you want, most of the patients are going to go for total hip replacement. So if you too much displace, then you will not be able to do total hip. There's one important message from this lecture. If you have to do some form of osteotomy, do not displace either medially, laterally, anterior, posterior, or angulate them much. The reason is they are likely to come for total hip replacement. So do not burn the bridges after the osteotomy. So what is the classical osteotomy? This is very important in exam for all of you, that this is a very classical description of McMurray. Oblique, it is not transverse, it is oblique. I will show you the example x-rays. It is oblique intertrochantric, not subtrochantric. People did all sorts of osteotomies, which is not allowed. So it is oblique intertrochantric osteotomy, displacing the shaft fragment upward medially until it hits the edge of the medial above the lower end of the acetabulum. So the amount of displacement McMurray described very much. So why it was displaced so much, I will tell you what is known as, what is called as the armchair effect. So again, I'm repeating, it is an oblique intertrochantric displacing the shaft upwards medially until the medial edge abuts the lower edge of the acetabulum. And that's the way he described this osteotomy. And that's the reason at that time there were no implants, of patients were put in hip spica for 3 months. So what is this osteotomy? It's a medial displacement of the shaft. Exercise, no influence on the magnitude of acetabular pressure. Very important statement I'm putting. And what happens, I'll tell you how the pain gets relief. Again, medial displacement of the shaft, exercise, no influence on the magnitude of the acetabular on the pressure. But there is a beneficial effect, can only result either by reduction of muscular force because the whole trochanter is gone up. So that's why the abductor mechanism gets relaxed. So that is the muscular forces on the hip gets reduced. And that's the reason you get a relief of the osteoarthritic. Or there is unintentional, you can't do it intentionally. There's the unintentional rotation of the femoral head, accidentally eliminating the incongruous part. So this is your luck sometimes. That is the arthritic part turns to non-arthritic. What is the turn of the head takes place, but that is unintentionally. So what happens with McMurray? Medial displacement, no exercise influence on the acetabulum, but there is a muscular forces get reduction. Beneficial effect that the head sometimes turn unintentionally. So it can, good part of the head can come under the good acetabulum, and that's why you will get a relief. Because there is no way we can change the rotation of the femoral head, because there is no way with McMurray we can do it. So this is a very important statement of the important biomechanics of the McMurray. If you write this in exam, probably examiner will understand that you know the subject. So McMurray disadvantage. change in the biomechanics. There's a shortening of the leg because there's too much of medial displacement takes place. And due to displacement, difficult to, if you displace too much, then it is very, very difficult to do THR. So this is one patient. My one of the other was not Dr. Dholakia. Dr. J.C. Tarapurwala was one of the teacher of my teacher. This was he was again trained in Liverpool, but he didn't work with McMurray, but the osteotomy he learned there in the Liverpool. So Liverpool, a lot of osteotomies were done in 50s and 60s. And he had come from England at that time. And when I was a houseman in 76, he did this operation. It was an avian. It was not a true indication, but like an arthritic. Secondary to the traumatic slip capital it was capital epiphysis. And look at this. He did a classical osteotomy. Let me show you this classical osteotomy. Look at this. This is oblique. Okay? Intertrochantric. The medial, the shaft has to move medially till it abuts the acetabular edge. All of you are clear?
Yes, sir.
Okay. Second important thing. Look at what has happened to the trochanter. Trochanter has displaced far laterally, so there is a offset has changed. The abductor mechanism has changed, and that's why the hip will have a less pressure on the acetabulum because the body lever arm and abductor lever arm are now getting equal. A lot of displacement the trochanter which has taken place. So that is very important statement that is a reduction in the force of the abductor and there is an increase in the abductor lever arm. That's why the equilibrium is trying to maintain. That's why the acetabular pressure is low. So that's why it's important. And now, when you do such a displacement, you must have never seen young boys. There is an amount of abduction you require for this patient is 40 to 45 degrees. 45 degrees. And that's the way you put a hip spica in 45 degrees. Now, the boss went after the operation. He said spica is done and boss went after the operation. Now, there was a call came to me as a houseman that the patient is, we are unable to shift the patient in the lift because at that time the lifts were smaller lifts. And with this abduction, there was no way, and this patient was on the 7th floor. So there was no way I could shift this patient. But I was lucky, but I got an idea that turned the patient on the side and I could shift the patient. That's the way I remember this operation. So what happens? 10 years. Look at the remodeling of the patient. 10 years. Everything was no pain, nothing. Remodeling took place. This is 37-year follow-up of this patient. So complete remodeling, but you will not be able to do a total hip unless you do something else, which I'll tell you why. Don't go on only AP X-ray. All post-osteotomy lateral X-ray is mandatory. Shoot through lateral X-ray. Orthopedic surgeon has to take. Most technicians do not know. I'm going to show you lateral X-ray of this patient. AP looks fantastic. Srikunj Bhai says, get the operation tomorrow. So everything is available. But look at this, lateral X-ray. So there is no way you can negotiate inside. So that is the thing which happened with this patient. Now, if you have to do it, we got to do re-osteotomy or get the trochanter out, get the trochanter detachment, try to get the medial, try to get sometimes a customized implant, custom implant. But look at the life of this patient of 37. Look at the remodeling which has taken. So the McMurray does work, but this is the situation. But today we will not displace so much. So we are doing something else, which I'll come to it. Anybody knows this plate?
Van Wright plate.
Correct, Van Wright plate. This is Van Wright. I had opportunity to meet Van Wright when I was on an MCH course. He was 92, I think, 1992. But he just came for a lecture to see us because most of we were about 26, 27 MCH boys. So he just gave a little short lecture. It was not up to the mark, but we could see him as a Van Wright. He's also from Liverpool. So this plate does not allow displacement of only this much. Can you see this? This much only. So what we used to do a subtrochantric osteotomy, and this is called as a spline, and this is called as a plate, and here is the screw mechanism here. So we have to put a introducer. We thread it, and there is a big bar here. We need to hammer it into the trochanter. So the length of this spline depends on your level of the osteotomy and what is the height of the trochanter. It is from 2 inches, 2.5, 3, 3.5, something like that. So that is the way we used to put it, and we used to put this put the screws. Here you don't need any hip spica. And if you look at the lateral X-ray, also there is no much displacement because it is a controlled in both sagittal and coronal plane. So this is the way my boss did a lot of Van Wright plate for osteoarthritic and non patients. So this is one of the osteoarthritic patient actually. I have seen this gentleman after 50 or 55 years actually. He didn't go through a surgery, but when around 2007 he wanted me to do the surgery. Unfortunately, medical problems were high. I couldn't operate this patient. Anybody knows this plate?
Mueller's?
No. This is
Tupman plate.
Tupman plate. So this allowed a fair degree of this because Van Wright plate did not allow much displacement to take place. But if you want to do it for non-union and all other things, you require a little more displacement. What you see in this, almost hitting the lesser trochanter, hitting the acetabular H. It has remodeled it already, and this is the way the Tupman plate was. And it used to come in a different sizes in the displacement. How much you want the displacement? There are 2 or 3 displacement osteotomy plate used to be, and we did it totally because we can't enter, so we have to detach the trochanter. And this is a Chandler trochanteric wiring, and we were able to do it totally straightforward without difficulty. Because again, there is no problem of sagittal and coronal sagittal plane. So you will be able to do it. So that's about the McMurray. So very important 2 things again I am repeating. It is a oblique intertrochanteric osteotomy. Medial shaft is displaced till it gets abut against the acetabular margin. That's the way he described. And I forgot to show you what is known as an armchair effect. Let me go back to my back slide and I'll show you what is armchair effect. See, this is the arm, and this is the chair. Okay, armchair. Probably you must not have seen the armchairs. Today many people do not use the armchair because of the back pain and other thing. So this is the way the armchair used to be. Okay. So the second was the Putti osteotomy used for a non-union fracture. Is also displacement, but it was horizontal displacement. It was not oblique displacement, with distal fragment transported medially beneath the fracture site. So it was not an oblique osteotomy. It was a straight transverse osteotomy going under the non-union area. These osteotomies, how this works on osteoarthritic hips, this either McMurray or Putti or few other osteotomies. Rationally of the treatment remained the basic equilibrium between biological component, that is called as a tissue resistant stress, and called mechanical component to decrease the articular pressure. So we have to balance between the tissue resistance and articular pressure, mechanical, both you have to reduce. So biological may not be possible for us because tissue resistance stress may not be possible. At least can you do something mechanical to reduce the pressure on the acetabulum and the head. So there was a possibility of doing this by decreasing the load. That's why we always ask our patient to reduce the weight. so that you can reduce the pressure on the acetabulum and the femur arthritic head, or increasing the portion of the articular portion. Either one of the things you can do, either decrease the load or increase the pressure, so that per square millimeter area available for the articulation is much more. We will come to that, how we can do this. So how do we decrease the pressure? By what is called as a temporary hanging hip operation. This was described by Voss. This operation is completely absolute. It is a historical, but I had opportunities to see this operation by my chief. What he used to do? Open the hip, just dislocate, do a little debridement, release the ilius vas, cut the adductor, and cut the abductor also. So it was called hanging hip operation. Reduce the forces on the hip. It was so disaster, I tell you. So this operation is out of question. Okay. Now, decreasing the load, which we said by unintentional thing which is going to happen with McMurray, and plus abductor mechanism is going to change. So decreasing load is a McMurray. Any displacement of osteotomy of this will be a McMurray osteotomy. So it is still possible to do this, and that is the principle of McMurray of decreasing the load. Now, second part is very important, which is more biomechanically sound, and it is increasing the portion of the articular surface, so that you have extra couple of millimeter of articular surface articulating to the acetabulum. Either you do varus osteotomy, that is called Pauwel 1, or you call Valgus osteotomy called Pauwel 2. I'll explain that, what is meant by Pauwel 1 and what is meant by Pauwel 2. Pauwel 1 is usually varus osteotomy, and Pauwel 2 is a valgus osteotomy, which will come to it. So it will reduce the pressure on the articular surface. So indications of arthritis: patient should be very young, should not be old. Secondary occupation, good congruous, possibly good congruous hip. There may be mild reduction in the joint space, and subcondylar sclerosis cyst may not be a contraindication for this operation. So we were discussing last on that the subcondylar sclerosis indicate the stress distribution, which I told you. Sursil are 3 or 4 types of sursil. Normal sursil, your triangular sursil, then you get a protrusive complete sursil. So that will also show you how the Pauwel it works on the sursil. Pauwel has shown the quality of the bone depends on the magnitude of the stress. Whenever there's an extra stress, you get a new bone formation, you get a sclerosis, and that was the principle of Pauwel. So Pauwel 1 is a varus osteotomy. Pauwel 1 to Pauwel 2 osteotomy. They are joint preserving operations. Decreases the articular pressure by increasing the weight bearing surface area. Secondly, decision of P1, that is Pauwel 1 and Pauwel 2, will depends on the femoral head, whether it has turned in and out, which I'll explain you. In means when you do an abduction view, that it has to go in, and that's called in. That is the way where you do that. And when it is out, when it is in abduction, when it is in adduction, then it is outward, which I'll show you X-rays also. So this is important, Pauwel 1 and Pauwel 2. What the head does. How, now if you have to go back to what my original slides were, where what was the K, what was the R, and what was the M. Again, you have to recollect yourself, which is important. Technique of varus, you can do 15 to 40 degrees, not much more. Adductor, you need to do tenotomy. The tension of the abductor and ilius vas is reduced automatically due to upper migration of the greater trochanter and lesser trochanter. So the abductor lever arm changes. The shaft is displaced 1 centimeter medially. The shaft is displaced 1 centimeter medially. What the effects are? Increase in the weight bearing surface area. R is moved medially. R was laterally because the shaft has come to medially. So what has happened now? The body lever arm has reduced and abductor lever arm has increased. That's why the resultant force has reduced. Clear? Is it
Yes.
clear?
Yes, sir.
Yes, sir.
I will show you which is more important. Now look at this. So this was the pressure here, unit pressure was 220 unit pressure, and after osteotomy it has become 16 per square centimeter. Reason is the weight bearing small triangular area has converted into a very large area, and look at what has happened to the trochanter. It has shifted here. So the abductor lever arm has increased. R was here, R has moved here. This shaft has moved medially, and that's why the whole R has moved medially. The body lever arm has reduced, abductor lever has increased, and this will reduce the pressure and increase the weight bearing area of in the acetabulum, and that's the way you will get a reduction in the pain. Crystal clear?
Yes, sir.
Yes,
Yes,
sir.
sir.
Very important slide for Pauwel 1. And you look at this X-ray of one of the patient. This is, can you see the sourcil? It is mere triangular sclerosis. And after surgery, look at the sourcil, how uniform it has become. It has become. And everything gets completely remodeled. And that's the one Pauwel 1 Valgus Osteotomy. There will be some amount of shortening in this patient, which has to be accepted. So what about Pauwel 2? Here, there is a large deformed femoral head, and it is subluxating, where we have to do tenotomy of adductor iliopsoas both. Greater trochanter is moved upward to reduce the abductor arm. Shaft is displaced not medially but laterally. Here, weight bearing surface is increased. R has been forced medially, which I'll show you on the X-ray. R is reduced due to the even distribution. Let us come to the slide X-ray. Look at this now. Here was the subluxation. It's a large head. It is usually Putti's type of head, usually a large head. Now the R, look at the R has moved here medially, even though shaft has shifted laterally, but R has moved, resultant force has moved medially. And look at the trochanter. Trochanter has shifted. So even though it was a valgus type of osteotomy, the abductor lever arm has changed a little bit, not major. But here, most important, R has shifted medially, and that's why you get an increased area of the surface area. Here, this is a usually large head, which you are going to accommodate inside. So this is known as Pauwel 2. It is a valgus osteotomy, reduction in Q transverse component leading to reduction in R. The transverse component pushes the head medially. This part of the component, there is no figure here because you have to use biomechanical different calculation, what is called as a transverse component. So the head is pushed medially in this case. Remember this much. Valgus osteotomy, R has moved medially, but the shaft exercised laterally. But the transverse component of this geometry has been pushed medially, and that's why the R has pushed on the medial side. And that will reduce the abductor lever arm and increase the abductor lever arm and reduce the body lever arm. So one example of this, look at the sclerosis here. Look at the outflowing head. And that's in spite of some degree of coxa valga, still the osteotomy was done, with the valgus osteotomy is done, and you get an amount of this reduction in. I'm going to go away from the slide. Now, we'll come to some other osteotomies. So is this clear for Pauwel 1, Pauwel 2? Mac 1 is okay. Now we'll
Yes.
go to other osteotomy. What are the good indications for intertrochantric osteotomy? All malunited trochantric fractures. If they are in the coxa-vara, so this is a very good operation intertrochantric osteotomy. All pseudoarthrosis in the fracture neck. When there is a fibrous pseudoarthrosis, I will come to that. Fibrous pseudoarthrosis, if you do a intertrochantric osteotomy, the fracture union is very good, very good. Congenital coxa-vara, excellent operation. All of them I'm going to show you. AVN involving very small area, less than 10 to 15 or 20% of the area, then it works, otherwise it does not work. And that's why Suzioka operation went on disreputed. So shortening or legging, sometimes we do it, very rarely. I had done in my lifetime only twice for subtrochantric. Okay, intertrochantric, good indication. The second indication is coxa valga with subluxation, chronic capital slip episis, when there is an excessive anteversion. Putti is when you want to do intertrochantric osteotomy. Spastic cerebral children. Fresh fracture neck with vertical, if there's a Pauwel angle is much more than 60 or 70, then you can do a primary intertrochantric osteotomy also.
Hello, sir. Hello.
And reduction in the moments, and we should have a good free range of motion. So we do intertrochantric Pauwel's osteotomy. It's called as a Y reposition osteotomy, which is indicated for pseudoarthrosis of the fracture neck femur with absorption, change in the inclination, and from vertical shearing force to a compression force we can convert. And this is one of the best operations you can have for especially for a fracture neck femur or a congenital coxa-vara and few other things. And if you look at this is a non-union. The Pauwel's angle is something like 75, which will be converted into 25. Instead of vertical shearing, you have a compression force, and that's the way the fracture will heal. So this is one of the congenital coxa-vara, a diagrammatic representation. This is known as a Fairbank triangle. If you have an X-ray the Fairbank triangle like this, it is known as congenital coxa-vara. It's very classical, and that's the way we do a Y type of operation, and we convert this from you look at the shearing force here, and now look at the compression force here. The same principle like any fracture neck femur. So you convert this. You look at this. This is a congenital coxa-vara. That's a triangular Fairbanks triangle. This is after osteotomy, and look at this after almost 25 years or so. Is a complete remodeling has taken place. And look at the sourcil, so well formed sourcil now, in acetabulum. So this is this osteotomy beautifully works, but this requires a lot of mathematical calculation. This is one patient my chief operated when I was just houseman at that time, and this is the look at this. This is a triangular piece of Fairbanks, and this was congenital coxa-vara. And he did the osteotomy, but it failed, and he had a courage actually to do a re-osteotomy again of this patient. So this patient came after 3 or 4 years after that, and this coxa-vara was not good. At that time, I was a clinical associate. I had read quite a lot, so I did a lot of work on this patient. Look at the measurements which I tried to do it, and asked my chief to do it. This was one great thing of my chief was he will he will accept the suggestions and whatever we are putting the hard work on measuring this and all that he will accept because he was so big shot, but still he will accept your suggestions. And this is the way he did it. He did this operation with a type of Pauwel style, and look at the follow-up of this patient. So everything was beautifully. After 15 or 20 years, this boy came to me, and that's the time I took it out. I took the out implants because he was a young boy. So that's the way this operation works. So that is one part of the operation. So we do also intertrochantric varus osteotomy, and this is very classically we do for Perthes. And all of you know that now Perthes, the pediatric surgeons nowadays are very aggressive in operating these patients, called as varus derotation osteotomy. Now they don't take out a wedge much. They just do some amount of varus osteotomy, and also they do a trochantric epiphyseal disease in this patient, Perthes. So Perthes is an excellent operation for varus derotation osteotomy. So this is one example, again operated. You look at that, getting subluxated, and look at this. This is again a pediatric SP pendant plate, complete remodeling will take place of these patients. And look at the follow-up, 3 years. Still about 5, still there is some coxa vara as compared to the opposite side. But look at that. This is a complete remodeling which has taken place. So this is one of the wonderful operation. Perthes should be done for containment, and we should be aggressively treating this. Nowadays, we do not use this plate. We use something different plate where 2 screws will be allowed to go into the proximal fragment and 2 or 3 screws below. And along with that, they will do a trochantric epiphyseal disease also, so that there is no problem of getting overgrowing the trochanter. The another important intertrochantric osteotomy is the failed fracture neck femur, either intertrochantric or a little bit of subtrochantric area or some intertrochantric area. This is my own patient. This was a very huge fellow, some 120 kilo. And this was basically IT with subtrochantric extension, something different fracture. And I did this, and I did a primary grafting. Within 3 months, this man came out completely pulled out implant. He was a young patient, around 45 or 50 years. That time I never thought that I will be able to do totally by that time, but I thought I will do the osteotomy of this patient. And what I did was intertrochantric. I took out that wedge out and got into the valgus and put in, and I did some medial grafting on that side. And look at this, it's completely healed up. So this is a really wonderful operation as far as this is concerned. So I preserved the femoral head, and this fellow is almost 35 years. Now he came for me for a total knee replacement, and I did a total replacement for this patient. So I told you, this one more operation of a transcervical fracture neck femur. It has to be fibrous union, then this operation works. If it is pseudoarthrosis, probably this operation may not work well. So there should be firm fibrous union at the level of the fracture site at the transcervical level. Then this operation works beautifully. This is one more operation done by again my chief, and look at this how beautifully non-union is healed. It was 8-month non-union. So this operation works beautifully. And then sometimes you have to do a subtrochantric shortening, which is a high dislocation. Way back in about 2002 or 2003, before I came to Ahmedabad here, one of my colleagues was operating in some other hospital, and he was trying to do this surgery of a high dislocated, and I got a call that he is not able to reduce this hip after doing a Saltus osteotomy. So I went and did a subtrochantric shortening for him. And subtrochantric shortening, I just got the reduction done for this patient. So this is important of a subtrochantric shortening. Regarding Schanz osteotomy, which we said, we do it for an unreduced, for an unstable hip. We want to give some stability for these patients. When Schanz described, he describes at the level of the ischial tuberosity, which I'll tell you why it is biomechanically is different. And today we do a slightly different, because if we have to convert into total hip, then it becomes very, very difficult. So we do it at least slightly on the higher side, just inferior border of the acetabulum if you want to do a Schanz. It's an angular osteotomy at the level of the ischial tuberosity. Distal fragment, very important, is abducted, internally rotated and extended. Why I'll tell you. The angle of the osteotomy depends on the adduction view. So what we do normally, we take an adduction view and see that the iliac wing is parallel to the shaft, and that is the amount of wedge you have to take it out from the subtrochantric area, so that upper fragment acts like a shelf, and the whole weight bearing takes place on the iliac wing, because it does not allow the subluxation, proximal subluxation to occur. So it gives a shelf, that the upper fragment gives a shelf to the iliac wing. And that's why you have to get what is called as an adduction view. And adduction view should be parallel to the iliac wing. So it is anterior angulation. Why it is done? To correct the lumbar lordosis. And that is the reason it is the angulation we have to correct, because the lumbar lordosis, most of the patients have lumbar lordosis. And that's why the distal fragment is extended to get the lumbar lordosis into action. Proximal fragment abducts against the lateral wall, and its adduction increases the efficiency of abductor, which I'll just explain you on the X-ray. But remember, proximal fragment abuts against lateral wall, and it's whatever the adduction has taken place of the proximal fragment, it increases the efficiency of the abductor, which I'll just show you. So this is one X-ray, the height dislocated. You look at this broad teardrop, the small acetabulum, small head. Probably either it was either a CDH or probably it may be an old septic also, I don't know. But this is the one thing for an unstable hip. A 38-year gentleman. And this is the type of osteotomy we used to do. This was in 85. So he did, my boss did level of the almost like a inferior, just little in between. Otherwise, Schanz does at this level. Schanz described, but we don't do it. We do it slightly on the higher side. Now look at this. As the weight bearing will be like this. Okay? It will, this fragment acts like a shelf. It's like a shelf. Look at the now important. What has happened to trochanter? It has shifted completely laterally. Completely shifted. So the abductor mechanism has tightened and the offset has changed. And that's why it will have a better abductor. It will be better abductor. It will have a better abductor. I go back to the previous slide, see where the trochanter was. Look at that. The trochanter was here. And then now the trochanter has become like this. So the abductor lever has completely changed. And that will increase the efficiency of the abductor. Is it clear to all of you?
Yes, sir.
So, shelf and abductor shifting. So that is the way the Schanz works. Now what happens? Here we take out a large piece of lateral wedge. So the knee goes into valgus. So these patients, all Schanz patients, when they operate in children, they develop an arthritic knee. Because secondary arthritis develop because of the genu valgum. And now that is the reason we don't do now too much of this. But now if you want to do, then we do a secondary osteotomy at the level of the knee after some time into getting into varus. But sometimes because the shortening is so much in these patients, the most patients, they want the lengthening to be done. So now there are young enthusiastic surgeons, they do this operation together, Schanz plus lengthening. The lengthening is done into varus. So this patient came after some time for lengthening, and my boss was not doing Elizura. So he asked me to do Elizura. Well, I did Elizura for this patient. And look at that. I have to got into the varus. So I left the plate there because it was many years. So I left the plate there 10 years. So I tried to negotiate a couple of this one. This is a hybrid frame which I used. And I did a varus lengthening. And look at how the bone is formed, so well formed. And almost I got about 3.5 inches of lengthening for this patient. The other is has and Dunn's. This is also done for unreduced DDH, CDH. Osteotomy done below the lesser trochanter. Lesser trochanter displaced into the acetabulum as a proximal fragment is adducted. It's not a very good operation. The second is sometimes we rarely do a trochantric osteotomy. And this is done mainly for the old Putti where you need efficiency. So we can either do a trochantric osteotomy, put a screws or wire, whatever the way, which is not very commonly done operation. We do it this trochantric osteotomy when there's an impingement taking place, when you do a total hip, and after total hip, once you abduct the hip will dislocate because this trochanter gets impinge against the acetabular wall and the hip will dislocate inferiorly or posteriorly. So this is the time we do require either subtrochantric shortening or we do a trochanter detach and bring the trochanter down. This is one of the patients which I did in Shelby. This was a CT scan of that patient, and that's the inside story, nothing major. And a detached trochanter got into this one, and you look at the complete healing, fair degree of ling length, and whole abductor mechanism is reconstructed extremely well. And that's the way we do it, this trochantric osteotomy. I don't think it's going to work. Okay, don't worry. This is historical. I had told you already in my first part of the lecture. These are osteotomy. We do it for intertrochantric. This is, anybody knows this operation? Anybody?
Yes, dimensional.
Garment osteotomy.
Yes. What we used to do, we used to detach the trochanter, osteotomize the trochanter. This medial big, we put it inside the shaft and put a plate and other thing. So there's a lot of medial displacement. Valgus will be created and impaction into the canal. But this operation was a morbid operation. Patient had a lot of shortening, a lot of complications. So this operation is taken out as far as we are concerned. What is called Diamond Houston. I had opportunity to meet this gentleman, Diamond Houston. He came to KM Hospital, Mumbai, and he did a couple of other operations. And he was on the teaching faculty at KM Hospital. That was a special occasion. That's it, Srigunj Bhai.
Yes, sir.
All the operations, as far as the osteotomies on the femoral side are concerned, most of the operations we have covered it.
Yes, sir. Yeah.
Anybody wants to ask any questions, we are welcome.
Yes, sir. That, one question was that one boy asked that how you are going to decide the angle of osteotomy?
In where?
For Pauwels.
Well, so you have to take an abduction view. The head is going inside. That is the amount of abduction. That is the amount of angle you require to do it. And you got to know. You got to use image intensifier. See that the head goes inside completely. We might have to revise the cut sometimes. So it depends on the adduction and abduction view.
Okay, sir.
So because
Okay,
that is very important because you can't do it again and again.
Yes, sir.
Okay, sir.
Okay. Thank you,
Okay,
sir.
sir.
Thank
Thank you,
you.
sir.
Thank you, sir.
Okay,
Thank
we'll
you,
leave it. Yeah.
Yes, sir.
Thank you.
Thank you, sir.
Thank you,
Okay.
sir.
Yes, sir.
Thank you, sir. Good
So
time.
we will have another lecture. When is that another lecture?
Yeah, we'll arrange tomorrow, sir.
Okay.
Tomorrow evening, same time.
Tomorrow same
Tomorrow,
time.
same time, sir.
Tomorrow.
Okay, done.
Okay, sir.
Okay. Good night, sir. Good night, and thank you.
Good night. Good night.
Thank you. Good night, sir. Thank you.
Okay, sir.
Thank you, sir.